Hello all. Today we are going to discuss about diagnosis and management of vulval intraepithelial neoplasia. This is the new talk, the 2024 January volume, which has got this new information about VIN. There was an old talk about it, which is of 2011. So yes, now new talk has come and new information has come. So it's highly likely that in the exam, they will ask you SBA from this talk. You all know me very well. I'm Dr. Shweta Santhalia and course director of MRCOG. So the students who are looking for July attempt for MRCOG Part 2, they can join MRCOG for organized preparation if they want to. And the mega course includes the free crash course, which has the EMQ question solving tips and tricks, which helps you in succeed. And presently it's running on 40% off, so you can join just for £299. So those who are looking for guidance and to start in a right manner from the beginning for July, they can join us anytime. So let's start the talk. If we talk about the key point about this talk, earlier the classification used to say that usual type of EIN and differentiated type. So now they have changed it. The classification has been changed, and they say that the high-risk human papilloma virus related VIN are called vulval high-grade squamous intraepithelial lesions. So the short form is VHSIL. And the HPV independent one or differentiated one is called DHSIL. So VHSIL and DHSIL is the new classification. So it's not the usual type and differentiated type anymore. It's vulval and differentiated type. So vulval is the one which is HPV associated because it's the more common one. Now, what is the other change in this talk they have mentioned is earlier the surgical treatment, wide local excision was the first line treatment. But now first line medical management also they found is appropriate if you have confirmed it vulval high grade squamous intraepithelial lesions. So for HPV associated one, the first line medical management is also appropriate is the new information they have highlighted in this talk. If we have properly selected the patient and adequately counseled them about the risk of occult disease and they are ready to go for the medical management, then first line medical also can be tried, which is the topical treatment with imiquimod. So that's what they have highlighted in this talk. Surgical management is needed for differentiated, which is this differentiated vulval intraepithelial lesion is more detrimental and more dangerous compared to the HPV associated one. So for that, surgical management is what is mandatory and preferred and recommended is what they mentioned. As 10% of the HPV associated one and 50% of the differentiated one progresses to squamous cell cancer over 10 years. So it's quite significant. Half of the differentiated one is going to progress to cancer and 10% of this is going to progress to cancer. That's why there is a possibility of primary medical management in this. But for differentiated one, only surgical management is recommended. So if we talk about incidence, the vulval HSIL which is the HPV associated one, is an uncommon condition. And if you see, the study says that it is approximately 2.9 per 100,000 person year between 91 to 2011. Now, if we talk about differentiated one, it is further lower. It is 0.05 per 100,000 person year. So definitely the HPV associated one is more common compared to the differentiated one, which prognosis is further poor. Now, if we talk about etiology, the high risk HPV associated pathway, we all know that high risk HPV are HPV type 16, 18, 33, and many more. So there is vaccine also for 16 and 18 is covered, but 33 and further different type of viruses are there, which is not covered by vaccine. So in the HR-HPV associated pathway, sexual intercourse, smoking, immunosuppression, these are the risk factor. These are the risk factor for VIN of HPV associated. So smoking increases the risk, immunosuppression increases the risk of acquiring the HPV infection and then further leading to VIN, and that 10% will convert over 10 years to cancer. The predominant type is HPV 16 and HPV 33 with the median age at diagnosis of 49 years. So this actually presented a little early compared to the other one, the differentiated one, which developed in the background of lichen sclerosis and other dermatoses. So that presented little late. So that will be, the differentiated one will usually present around 70 years of age, while HPV associated one will present at a younger age, which is around 49 years of age, and there will be these contributory factor as well. So in exam, sometimes they ask you that which is the most common type of HPV which leads to VIN and cancer. So HPV 16 is what you should choose as a high risk HPV which leads to VIN and followed by cancer. As we saw that HPV is responsible for this kind of VIN, and the other is the differentiated one, in which because that is high risk, there's approximately 68% of lesion are already having the cancer at the time of diagnosis. So 68% already have the cancer present. That's why the surgical management is preferred for this. And the main risk factor for this type, differentiated type of VIN, is lichen sclerosis. So under the background of lichen sclerosis, if you see a lesion, then it will be most likely differentiated VIN, and there is high risk of cancer in such situation. And the median age of diagnosis of differentiated one is 70 years. As I told you, it present late. How you can prevent it? The primary prevention will be vaccination. For HPV1, you can give the vaccination which covers, there is bivalent and tetravalent vaccine. So you can cover 16, 18, and some benign viruses by that. While for lichen sclerosis, for preventing differentiated one, you have to treat the lichen sclerosis properly. And if you treat it properly with the steroids, you can avoid progressing it to VIN followed by cancer. Now, if you talk about histopathology, if you see, VIN doesn't have a characteristic, the look wise, the clinical manifestation wise, there's no fixed pattern for either HPV associated or differentiated type of VIN. You will not see clinically any clear cut thing saying that if it looks like this, this is HPV associated. If it looks like this, it is differentiated. It doesn't say like that. So in histopathology, if you see, histopathology can help in diagnosis. So if this is the normal looking basal endothelial, and if you basal epithelium of vulva, and if you see this one, this is the HPV associated VIN. So in this case, there will be parakeratosis, thickened epithelium, there will be loss of maturation, scant cytoplasm, nuclear hyperchromesia, and atypia and mitosis. So this is how it looks like. There will be more nucleus to cytoplasm ratio. That is the usual character of any cancer developing or any pre-malignant lesion developing, and atypia and mitosis are the main characteristic feature. So you will be seeing parakeratosis, thickened epithelium, so you can appreciate that in the histopathology. And the most important thing in the immunohistochemistry will be that this will be positive for P16. So this can also be asked as an SBA in exam, that this will be positive for P16 and differentiated type will be negative for P16 while positive for P53. So they say that absence of P16 immunostaining is an essential feature for differentiated type, because this type is P16 positive. So this will be P16 negative and P53 positive. So that will be an important differentiating feature between this. And this differentiated VIN again will be having the parakeratosis, thickened endometrium, epithelium, and atypia, and all the usual feature of pre-malignant lesion will be there. So if you appreciate in this, there will be abundant eosinophilic cytoplasm. So this is what make it difference in histopathological examination to uh, diagnose the differentiated type of VIN, as well as it will be in the background of lichen sclerosis, which by history also you can differentiate and diagnose it well. But immunohistochemistry is something they have highlighted. So you should remember that this is P16 positive, which is HPV positive, and this is P16 negative and P53 positive. Now, if we talk about clinical manifestation, as I told you, there is no clear-cut differentiation between both the type, or there is no clear-cut differentiation between VIN from benign lesion, because uh, all can overlap, the clinical feature can overlap. So there is no unique identified characteristics, but most of the time it present with pain and pruritus. So pruritus in vulva is always should be taken seriously, and you should evaluate it thoroughly. So pain and pruritus in 64% and 30% there will be a visible lesion. So if you see here, usually it is the HPV associated lesion will usually present as raised papillary lesion with well-defined border. So if you see, it is having a well-defined border, and it's like a papule. Rough keratotic surface, uh, though the sometimes it could be erosive as well, but this is the usual characteristic. The number and distribution can vary. It could be multifocal. It could be in different areas, as well as in 1/3 of the cases, it might be associated with anogenital problem as well as vaginal involvement. So you should look for other areas as well, because HPV may lead to involvement of vulva, vagina, cervix, at the same time anogenital area. So you should do the vulvoscopy and look for lesions everywhere is very, very important. So multifocal is something you should always look for. 50% of the cases is multifocal in cases of VHSIL. The lesion can be erythematous, can be white, can be pigmented, but whenever in exam they give you pigmented lesion, you should always think about the malignancy and take a biopsy from that. The commonest site, if you see for this, is labia minora and perineum. So that's the commonest area to look for it. Now, if we talk about HPV independent one, which is seen in the background of lichen sclerosis, so you can appreciate in this picture that the anatomy has been lost, the clitoris has been lost, all the anatomy it all got fused. The vulva has, the labia minora and majora all has lost the anatomic configuration, and the labia has got fused, and there is atrophy. And you can appreciate the lichen sclerosis in the background, and you can see this lesion of uh, differentiated type of VIN. So it may present as gray or white lesion. So it may be gray or white, rough surface, may present as white plaque, pink, red, or nodular lesion. Nodular is also very significant for cancerous lesions. So nodular means you should always think about VIN or cancer. It may be unifocal or multifocal, but yes, multifocal is more of the HPV associated type compared to this, and may present with additional diagnostic problem because of the background dermatosis. Whenever a lichen sclerosis lesion doesn't respond to steroid, you should always consider differentiated VIN, and you should always consider biopsy in such cases, because if it is not responding to steroid, you should think more sinister. If we talk about diagnosis, so diagnosis is always by biopsy. Whenever you want to rule out any pre-malignant or malignant lesion, the biopsy is must. So biopsy is always recommended to support your diagnosis. What kind of biopsy? This is always exam favorite question. So you should always do incisional punch biopsy. You should never do excisional biopsies for diagnosis. So incisional punch biopsies or cold knife biopsies is what you are supposed to do. Minimum 4 millimeter width and minimum 5 millimeter depth you need to properly evaluate the lesion, and it should involve the adjacent normal skin to compare. If possible, you should make a diagram from where you have taken the biopsy, so it helps you in further planning of treatment, as well as correlating and corresponding to the previous picture will help you in future prognosis as well. So if multiple biopsies are taken, it is very important that you show it in diagram from where all areas you have taken the biopsies. Universal P16 and P53 immunohistochemistry is recommended to distinguish the vulval HSIL to differentiated VIN. Okay, so now you have by clinical appearance, by biopsy, and by immunohistochemistry, you have diagnosed the type, either it is HPV related or non-HPV related. So if it is HPV related, as I told you, surgical management was historically the first line treatment for all VIN, but now it has changed. Wide local excision was the preferred approach earlier, but now they say that medical management as a first line also can be used. Though it is an off-license use of imiquimod cream, but still it can be used as a first line in selected cases where you're not suspecting occult cancer. So it's very important that you do the case selection properly, and then you can tell them and inform them about all the follow-ups, all the possibility, and if they accept, you can do the medical management as a first line. So wide local excision, yes, it's always there and it will be there as a treatment option, but first line medical is also emerging as a promising treatment modality for VHSIL. So imiquimod is an immunomodulator, and it helps. It has to be used 16 weeks or at least up to 4 months to give the complete response. Because the VIN progresses to cancer slowly, then always you can give a try of medical management is how they are justifying, especially for the multifocal lesion where surgical excision will lead to a lot of morbidity, because any vulval surgery will lead to vulval disfigurement, and that leads to psychosexual and physical morbidity for the women. So if there are multifocal lesion, then obviously the medical management would be more preferable by the women to avoid the multiple excisions of that area leading to disfigurement. The other medical options, the other medical agent recommended is pseudophobia 5-fluorouracil and cinecatechins, but at the same time, still there is not enough. They tell that it is promising, but at the same time, it is still under trial, still not enough evidence. So in the exam, mostly you have to choose imiquimod because that has been recommended, but these are still under trial. But these are other three molecules which are recommended and under trial for the treatment of vulval HSIL. If you talk about surgical management, then laser therapy and photodynamic therapy is also there. So ablation with CO2 laser is effective, but you have to always rule out the invasive disease if you are doing the laser therapy. Photodynamic therapy, it involves the administration of photosensitizing agent to induce the cell death. So these are the other surgical management recommended for the treatment. Surgical treatment, wide local excision. Earlier, they used to tell that you have to take at least 2 centimeter of the margin, and it should clear the complete lesion. So that all things has been changed now. So they don't recommend any particular uh, uh, size or any particular criteria like 2 centimeter clear area or something like that. They say that you have to individualize and treat them, and wide local excision doesn't have any further criteria of 2 centimeter excision of the clean margin. So Role of surgical excision should be individualized and patient-led, and after discussion of all the risk and benefit of surgical versus medical with the patient. If we talk about occult disease in the cases of VSIL, then occult disease is common and it's seen in approximately 9.7%, while we saw in cases of differentiated type, it's 68% already have the cancer in the background. So how you will understand that which of the VHSIL are high risk and which are low risk. So age, nodular lesion, and possibility of involvement of clitoris make them high risk. So there is high risk of occult invasive disease if their age is more, if the lesion is nodular, and if it is involving the clitoris. So in the SBA, they can ask you that which of the following are the prediction for occult invasive disease in cases of VHSL. So these are the three prediction factors. So how you will do the decision making? Again, explain the patient about the situation, take their opinion, involve the patient, give them all the treatment option, what are the risk and benefit, and then patient can choose. If you are giving them imiquimod, you have to talk about the side effect of imiquimod compared to surgical. The rate of complete clinical response may take longer time, 6 months or more, and it's approximately 80% success rate. So these all things you have to inform them. High risk of recurrence, you always have to inform because there is 26% chance of recurrence. So approximately 1 in 4 will recur, whatever modality you choose to treat. It doesn't matter, either medical or surgical, but 1 in 4 will recur. There is a risk of invasive disease in the beginning itself. There might be a occult cancer in the beginning itself. So follow-up is vital, is what you have to inform them. With imiquimod, what all side effect can happen? So there could be local pain, swelling, redness, skin changes, flu-like symptom. These are very common with imiquimod. Now, the other surgical option is skinning vulvectomy, where you are removing the vulval skin. Though it is rarely needed, but it may be considered if there is a big area, confluent multifocal lesion in immunocompromised women where it is difficult to treat. So you can consider skinning vulvectomy for confluent multifocal lesion in immunocompromised patients. So we discussed about the HPV-associated VIN, VHSIL, where you can consider imiquimod as an off-license use as a first line in selected cases where the age, the nodularity is not there, involvement of clitoris is not there, the risk of occult disease is not there, then you can consider imiquimod as a first line, otherwise surgery. While as we discussed earlier that in cases of differentiated type of VIN, it is always the surgical excision is recommended because one study reported that 40% of the women diagnosed already have invasive cancer. And if we see, 20% had occult invasive disease. So 40% have invasive cancer and 20% have occult invasive disease. That's why you should always recommend surgical excision for DVIN. Medical or ablative surgical modality like laser or photodynamic therapy or medical like imiquimod is not appropriate for DVIN. Prognosis, as I told you, risk of recurrence is always there. Recurrence risk is around 26% regardless of whatever treatment modality you use. So it's quite significant recurrence risk. How you can predict the recurrence? Again, high risk women will have higher chances of multifocal and multifocal will have high chances of recurrence. So age, which if there is simultaneously CIN or vaginal involvement of HPV, so CIN and vein, then it will further increase the risk because it will be multifocal for sure. Higher age will increase the risk of recurrence and immunosuppression will increase the risk of recurrence. So we saw in the beginning that smoking and immunosuppression are the risk factor for HPV associated VIN. So yes, these are all high risk factor and will increase the risk of recurrence. And again, the positive margins of the surgical resection is a very strong predictor and risk factor for recurrence. How you'll follow up? The suggested follow-up is definitely, because there is a risk of recurrence, you have to follow up. So 6 monthly for 2 years, and then annual up to 5 years is recommended. If they have lichen sclerosis, they require long-term follow-up because that will not disappear. So there will always be a risk of turning into a differentiated type of VIN. But in cases of HPV associated, 5-year follow-up is enough. Most recurrences occur within 2 years, so which is a good thing, that you will be able to pick it up in the beginning. That's why 6 monthly for 2 years and then annual follow-up. Follow-up will be in specialist vulval clinic who has the full knowledge of vulva and the appearances and recurrences, and vulvoscopy, colposcopy. MDT access will help in diagnosing the recurrence earlier rather than late. So follow-up is mandatory at least for 5 years, and in cases of lichen sclerosis and differentiated VIN, further longer follow-up is required. So this is the infographic. Now we have gone through the talk completely. So this infographic will be a quick revision and understanding about VIN. So if we talk about VIN, it could be of 2 types. One is HPV associated, high risk HPV associated, which is now called as VHSIL, and one is HPV independent, which is called as DVIN. 10% of VHSIL and 50% of DVIN progresses to cancer over 10 years. So this is very important figure. They can ask you in SBA what is the percentage of this progressing to cancer or this progressing to cancer. So you should remember it. Risk factor, a quick revision for VHSIL, smoking, sexual intercourse, and immunosuppression, and the median age is earlier than DVIN, so it's 49 years. For HPV independent, age and lichen sclerosis. Again, the median age is higher here, approximately 70 years. Primary prevention by vaccine in cases of VHSIL, and treatment of lichen sclerosis and compliance with steroid in cases of DVIN. Histopathological feature, VHSIL, acanthosis, hyperkeratosis, parakeratosis, reduced cell maturation. In DVIN, parakeratosis, elongated ridges, abnormal keratinocytes, and prominent bridges. Diagnostic approach, incisional punch biopsy or cold knife biopsy of all the lesions, immunohistochemistry to differentiate between 2 types, and colonoscopic evaluation and cervical and vaginal evaluation if needed. Management, surgical management, or in surgical management, laser or wide local excision or photodynamic therapy or skinning vulvectomy according to different situation. In medical management, imiquimod is what off-license use of imiquimod is recommended, sometimes as a first line in properly selected patient. These are still under trial and not recommended yet. Management of HPV independent, you will always do the surgical excision, and long term you have to do the proper steroid treatment for lichen sclerosis and planners to avoid further development of VIN and cancer. Prognosis, recurrence is 26%, which is quite significant. That's why you have to do the long-term follow-up, and you have to do the risk factor assessment and tell the women to avoid that. In cases of lichen sclerosis, treat them properly, and long-term follow-up is what is recommended. And at least 5-year follow-up is what you will do. So this is the infographic which tells you most of the important points about the TOG. Once you go through the TOG, this infographic gives you a quick revision of and understanding of the important points of TOGs. So I hope this became clearer to you before going to this 2 SBAs. So I hope that once you have gone through this TOG, you'll be able to answer this SBAs. So a woman is diagnosed with lichen sclerosis, placed on ultrapotent topical steroids. After 6 months, failed to respond to the steroids. So what would be your next stage in her management? So you can answer these questions in the YouTube. This recording will be there in the YouTube, so you can answer in the comment section and let us know if you have any difficulty or any recommendation about the future uploads. The other question is, what follow-up is recommended following treatment of VIN? So I hope it is clear now and you'll be able to answer this clearly and quickly. So I hope this understanding of the TOG has made your understanding for VIN very clear, how the classification has changed now. According to 2020, they have done a new classification which has come up, and definitely this TOG is very important from exam point of view. So go through it and remember it and do well in exam. And if you're looking forward to organize preparation for July exam, you can join us and contact us. Okay, thank you. So thank you for listening, and bye bye. And please subscribe so that you can get the notification of the future uploads.